All right, so we're going to transition over to principles of geriatrics rehabilitation, and I am so thrilled to be able to introduce Dr. Carly Trentman, who completed her med school at the University of Kansas School of Medicine. She completed her prelim year in internal medicine at the University of Missouri, Kansas City, and she followed her residency there as a chief resident. She currently serves as an associate program director for the residency program. She practices inpatient and outpatient physiatry. She focuses on treating patients with physical and/or cognitive impairments that can affect quality of life and ability to function through a holistic and multidisciplinary approach. She works closely with an interdisciplinary team, which includes nursing staff, physical and occupational therapists, dietitians, speech therapists to deliver quality patient care. She's contributed to collaborative research with the Brain Injury Research Center at Mount Sinai and participates in a national steering committee for brain injury. She has also contributed to chapters in textbooks involving common musculoskeletal disorders and nutrition. So both the issues that commonly affect our older adults. Her clinical interests include medical education, spasticity management with ultrasound guidance, amputee care, electrodiagnostic studies, and geriatric rehab. And with that, I will let Dr. Trentman take it away.
Thank you so much. Hello, everybody. I'm Dr. Trentman. I think there was a slight typo in that bio, but I actually did the rest of my residency in PM&R here at Mount Sinai, so happy to stay. And I'm over here at Mount Sinai West now. So thank you guys for inviting me. This is my third year with you guys doing this topic, so eager to be a part of it again. Let's get started. I have no financial disclosures in regards to this lecture. So like the intro said, I'm a physiatrist, so my background is more in PM&R. So my goal of this talk in general is not for you guys to become physiatrists, but to really grasp the rehab concepts, both clinically as geriatricians, as well as hopefully some help for your boards as well. So I actually have broken down my lecture and how it was organized via the blueprint. And so these are the general topics, which you'll see again, but that's all listed here. So I went ahead and as someone that also had to take boards and everything, first thing is to go to the outline, see what the topics is, what's going to be discussed. I do check this every year to make sure there's been no changes in terms of topics that you guys will be tested over, and it looks the same as the previous year. So here you are. May not be the highest yield in terms of medical content, but it's 3%, and we're going to cover all 3% of that. So this is further broken down by assessment of disability, assessment of rehab potential, aspects of rehab, and these are all of the subcategories in terms of aspects, and then rehab settings. I'll be going over all of this in this order, so hopefully that will be easy to refer back to. I did further do some digging just in terms of what's going to be, more for the exam, what's going to be the highest yield. You can see that you will likely not get tested over basic sciences when it comes to prosthesis, but definitely in terms of assessment of disability. And then there's kind of some in the middle, medium importance, but I'm going to cover all of it regardless. So we're going to start with assessment of disability. In general, this is specific, of course, to the more of the geriatric population. I don't necessarily use this scale as much for my younger patients. I treat mostly adults. I think the youngest I treat is like 17. So, but the vast majority of the patients I treat here are in the geriatric category. So to assessment of disability, so it's important to distinguish both clinically as well as for board studying what these different terms are. So the first one I want to introduce, of course, is frailty, which may be familiar to some listening to this topic, but the big thing to highlight with frailty is that it is more of a clinical syndrome. It is not one specific definition. So, you kind of look at it as a constellation of things. And this is important to see what the symptoms are. This can be self-reported exhaustion, low physical activity, unintentional weight loss, weakness, and it's specific in here. Some of the definitions I'll give I don't find as high as yield, but these specific definitions here I do find in terms of knowing how much weight loss it is, which is 10 pounds or more than 5% of body weight, and also weakness, grip strength in the lowest 20th percentile, as well as slow walking speed. To me, it's not enough to just say, okay, they have unintentional weight loss, that you have to kind of dive in deeper into the history. So that's something important. Now, the reason I was harping so much on that is because there's a lot of other terms that can get confused with frailty. And this is also something that we get tested on for our rehab boards, is the differences, because they can all sound pretty similar. There's frailty, impairment, disability, and handicap. So especially the term disability. Disability is different than frailty. Disability is you're unable to perform a particular activity or function. So when I go over these topics, I like to just use a patient that had a spinal cord injury, because to me it's a good framework to determine what these different definitions are. So if someone had a spinal cord injury, they would not be able, we're going to say someone with a complete spinal cord injury, maybe at a higher level, like in the higher thoracic region, they would not be able to ambulate due to a paraplegia. However, frailty, as we just mentioned, that's more of a clinical constellation of symptoms. So these are the two that get confused the most. And disability itself doesn't necessarily have to be that physical example that I just gave in terms of paraplegia. It could be emotional, it could be social, but there's some sort of activity or function that they cannot do. But usually it's limited to that particular activity or function, versus frailty is across multiple organ systems. Over 75% of the elderly population with frailty can complete their ADLs, their activities of daily living, which I will describe what those are in a moment. Now, the other two terms that can sometimes get confused are impairment. Now, impairment is just some sort of physical or psychologic abnormality that is a manifestation of the disease or the injury. So this could be paraplegia, like I said, which that's not actually relating to a specific function. It's just talking about the actual impairment. Another example could be like a radiculopathy from a herniated disc. It's some sort of impairment itself. Or like someone that had lost a limb, it would be the amputation itself is the impairment. It wouldn't be the function that relates to the loss of a limb. And then finally, there's handicap, which is the inability to perform or fulfill a role or life activity due to the impairment. So that could be something like cannot go up the stairs, cannot drive, it's some sort of, cannot say prolong sitting at a desk for 7 hours because of some sort of impairment or disability. So it's important to distinguish these not only clinically, but they can be kind of give me points for a test if you just know the definitions and the differences. So something else that we can test for disability, which that's, as I just defined on the last slide, you can, for diagnosing disability, you can actually you should ask the patient to perform a get up and go test. And this can be done in the clinic. It can be done inpatient, but I've seen it more done in the clinic. And as you can see, the big takeaway for this is, number one, the time in seconds for a get up and go test, or TUG, time to get up and go. It increases as age increases, as you can see here. So someone performing this in 11 seconds is actually well within the normal range if they're 80 or above, but if they're 60 to 69, that would technically be considered prolonged. And you can also see these predictive values in terms of how predictive it is for falls, for hip fractures, or requiring an assistive device. So it's a very useful test. Another test of disability for diagnosis can be the functional reach test, where basically if a patient is standing, and here's the kind of the photo I have of it. If they're able to reach more than 6 inches, that's a good sign, right? So you can see, there's a lot of words on this slide, which I'm not necessarily wanting to go into because it's more just talking about how to perform the test itself if you're going to have the patient do this in the clinic. But the big takeaway here is, again, similar to the last slide, depending on the age range and for here gender, the norms is slightly different. Now, something that we also use in terms of assessment for disability, this is something that the therapists and by therapist I mean like occupational and physical therapists. They will use this FIM scoring to measure kind of a patient's overall independence measure. This is broken down by independence level, which I'll go more into on the next slide. I think the big takeaway from here, me as a physiatrist, when I'm assessing a patient for rehab, and in general, what their functional assessment would be after they're, say, more stabilized from an acute illness in the hospital. I'm going to be looking at this. This FIM score can be kind of currently what they're needing or currently what their functional level is or what it was prior to them being admitted to the hospital. So you can see here, like 7 and 6 they're completely independent. The only difference is one is modified independence, which is basically like someone is independent, but maybe they have some sort of assistive device like a cane. Modified dependence, this really depends on the amount that the client or the patient is able to perform on their own. So you have to look at this and visualize the therapist kind of being at bedside. Like, is the therapist kind of having to help them ambulate about 50%, and they're able to perform the other 50%? Well, that would be moderate assistance, or we call mod assist. So as someone progresses through their hospitalization, hopefully as they're getting better, they may have been moderate assist, max assist, and they're progressing to min assist, supervision, et cetera. So this following slide is to just show you how what the actual sheet is that the therapists use. And this is how you can see here, this is on admission. Perhaps their score may be a bit lower than closer to discharge and follow-up. That's the hope. But we use this as a determination of their functional progress. And you can see here again, like if they're a 6 or a 7 in terms of levels, they're already independent. It's just a matter of device or no device versus anything lower than that. There's some sort of assistant that's needed, even if it's at the supervision level. So as promised, I wanted to go a little more into like ADLs or activities of daily living and compare that to instrumental activities of daily living, because this is also something that we measure, at the bedside or in clinic in terms of someone's, like a patient's rehab potential. So ADLs are more limited to, dressing, bathing, toileting, transferring, ambulation. Those are just activities of daily living. When we get into instrumental activities of daily living, that's a little higher level. That's going to be, we're checking if they're able to, do they go out and do their groceries on their own? Do they time their, do they get all of their medications prepared every morning? Are they handling their finances on their own? It's really important to distinguish these two things, because if someone's hospitalized and we're determining the safest place for them, whether that be home, acute rehab, subacute rehab, someone could be independent with their ADLs, but really not independent with any of their IADLs. And that's something to note for when we're planning their discharge, because they may be able to get around on their own in the apartment, say. This is a New York-based talk, so most of them are living in apartments, but they may not be able to do their groceries at all on their own like housekeeping, those types of things. And so that's something to consider in terms of their discharge plan. So it's really, as you can see from what I'm saying, like determining someone's rehab potential, it's multidisciplinary, it's multifactorial. There's a consensus definition that I threw in here that I'm just going to highlight you know, the key words here, which is really, what support do they, what are their personal strengths, first of all? What's their cognitive status? What's their motivation? What's their cooperation level? Because those, even if they do have the functional potential to do well, if we do not have buy-in from the patient itself, themselves, then the rest of it's kind of a moot point if they do not want to cooperate in any sort of rehab program. But also, do they cognitively have the capability to do that as well? Are they able to follow multi-step instructions? What are their medical complications? Do they have, say, a nutrition plan in place, or are they right now recommended to be NPO? If so, they're not necessarily ready for rehab yet. We need some sort of nutritional plan in place. And then familiar support. Okay, say their nutrition plan is they have a PEG tube or TPN. Who's managing the TPM? Are they independent in that, or do they have family support that's going to be able to help them after they discharge? So this is kind of a big. It's definitely multidisciplinary and multifactorial. So you can imagine how the therapists are involved in this, the nutritionist, the speech therapist, the physiatrist, geriatrician. So I wanted to emphasize that. So that concludes kind of the assessment for rehab potential section. I'm now going to be moving on to the aspects of rehab now. So now let's say that this hypothetical patient I'm talking about is going, they have all of these things in place. They look like a pretty good candidate to, say, get some acute rehab before they discharge home. So first, I want to introduce the acute rehab team. So if they're coming to acute rehab, that means that this patient is expected to be able to tolerate 3 hours of therapy a day, which is pretty intense. 3 hours of therapy a day includes, at minimum, PT and OT, or physical therapy occupational. I'll just abbreviate it PT and OT, and then speech therapist is SLP. They have to at least tolerate 3 hours of PT and OT. Speech can be included, but not all patients need speech therapy. You can imagine, say, there's an elderly patient with a hip fracture that is pretty independent otherwise. They're probably not going to need any speech therapy needs. If they're not having any dysphagia or cognitive deficits, they will be doing 3 hours of PTOT. But depending on the rehab, some rehabs are more specialized. So for instance, we actually in our department, our specialized rehab just moved to Mount Sinai Morningside, and they are a specialized brain injury unit as well as a spinal cord injury unit. And so they actually have more disciplines there than what a general rehab unit has, which is where I work, which is at Mount Sinai West. A general rehab unit has more of the, I guess, more the core therapists, which is PTOT speech. All of them will have that. Some of the more specialized may have neuropsychology or psychology services, as well as recreational therapy. All will have nursing staff, of course, 24/7. Most have chaplain services, most have nutritionists. So it really varies on the type of therapy, or the type of rehab center. Now, if a physiatry team is not available, there's another resource, of course, that geriatricians could use that I did some literature review on, called the Comprehensive Geriatric Assessment. So this isn't one that I personally perform, but looking over, other tools that could be in your guys' tool belt, this could be one that you guys could use, the Comprehensive Geriatric Assessment. It honestly mirrors a lot of what we do in physiatry. So it certainly, it addresses a lot of these the key is it's multifactorial, it's multidisciplinary, as you can see with this physical function of what you would be assessing. But it's basically going over many of the same things that we do, which is great. This is just a side note that, a little bit of differences in semantics of assistive technology versus adaptive equipment. Assistive technology is basically, all I want to say about this is the big umbrella. And within assistive technology, there is some adaptive equipment that can be used, such as car equipment, readers, electronic pointing, sip and puff systems for a wheelchair versus assistive technology could be something as canes, walkers, wheelchairs, hearing aids. It's really more just different ways you could, the umbrella versus the subcategory. These are just general categories that assistive devices can fall in. As you see in let's see, for instance, in the technology, look at all these different technologies that somebody could use versus equipment I have here on the right. You can kind of see the different equipment that someone may utilize depending on what their deficits are. So that's more of just a small note in terms of those are technically different things, but they're very intertwined. So next I want to touch on therapeutic modalities. So again, say your patient is now going to be getting rehabilitation. There are different modalities that the therapists can also use whenever they're getting their therapy. And so these are things such as heat, cold, hydrotherapy, light therapy, electrotherapy, manual, pressure, and acupuncture. I'm going to briefly go over these because these were all included as modalities to be discussed. So temperature, here's a little bit of background from the, physics back in the day. So remember, of course, temperature, that can have an effect on blood flow, viscosity, nerve signal conduction, and collagen. So heat in general can help with subacute and chronic processes. We use it a lot here on rehab, just warm compresses. If someone's having spasms, having low back pain from maybe a pretty intense day in the gym, they're having stiff joints, contractures. We use it a lot. However, there are contraindications. So if someone has an ischemic area, bleeding disorders, if someone's not sensate in general to any sort of area, I would not recommend any sort of temperature modality, heat or ice. And here are some other kind of contraindications like malignancies, traumas, too much edema, atrophy, areas of poor regulation. Within thermotherapy, there are different methods of heat transfer. So again, this is another throwback to physics in terms of conduction, convection, conversion. So I have the definition or the pictures down here as well to just remind you conduction is by direct contact. So I'll give examples clinically on the next slide, but there's the direct contact of the energy in terms of conduction from heat. Convection is more from heat that occurs by circulation, and then conversion, you're actually converting that heat into radiation. So clinically, these are the examples. Conduction would be like hot packs, paraffin bath. Convection would be something like a contrast bath. Say if somebody has some sort of abnormal sensation that they're needing contrast baths to, such as like Raynaud's or something that they're needing some sort of treatment for, you could use contrast baths as well. And then conversion is, ultrasound, which there is actually therapeutic ultrasound instead of the ultrasound that you just think for maybe scanning to see the shoulder joints. There's actual like heat ultrasound that the therapist can use on, sore muscles. And then there's also shortwave diathermy and microwave diathermy. I have not seen these clinically, but I have seen them on boards. So it's just something to know that that's an example of a conversion technique. Cold therapy, this would actually have local vasoconstriction. This can decrease pain as well. This is kind of more for acute processes is when we would more use this. So if someone had a traumatic fall and they're pretty sore in the area, maybe there's some ecchymoses in that area, like we could apply cold to this area. But again, contraindications, again, anybody that has any abnormal sensation, we don't recommend either of these. If they cannot communicate as well, that's something for both actually. If they can't communicate that it's too hot or too cold, we would not recommend this. And as well as arterial insufficiency, cold intolerance. So light therapy, that's ultraviolet radiation. We have electrotherapy. This is something like a TENS unit. You guys have probably seen where, you put the actual pads on an area where, say, someone's having like low back pain. We'll put like the TENS unit, and the mechanism is it's predicted it's from the gate control theory. where basically the pain fibers that we receive are the slower unmyelinated fibers that are called the C fibers versus the TENS unit. The theory is that these faster myelinated afferent nerve fibers are stimulating kind of quicker than the pain fibers, so it's going to distract the pain and hopefully cause a decrease in pain. So same concept, like if somebody's getting like a wax to their eyebrows or their, this is more in the beauty category, but if the esthetician starts tapping after you have your waxing done, it's the same theory. And then there's also massage. I'm sure most people know what a massage is, but in a rhythmic fashion can cause vasodilation, can assist in venous blood flow, and then manual therapy. This is more. I know our osteopathic colleagues do some osteopathic manual manipulation therapy, but it's on the somatic dysfunctions to improve their function. Pivoting now to devices. So there's a difference between orthotics and prosthetics. Orthotics are braces or other supportive devices. So these are just general examples. I doubt that this is something that would be tested, that you need to determine what's an articulated versus short articulated AFO or ankle foot orthoses. The big takeaway from here is just know that there are orthotic devices for patients that exist, definitely including elderly, that if they have drop foot, if they have difficulties in ambulation, that can really help. These are not limited to just the ankle and the knee. It can go all the way up to the hip. There's a lot of different material, they can be in steel, aluminum, titanium, leather, thermoplastics, but it's to hopefully assist them in some sort of ambulation or process. So here's more examples. Again, it's just more to show you the pictures of the examples. There are also technically there are dynamic orthoses. I have not seen these as much clinically, but they do exist. So orthoses are not only, or orthotics, these are not limited to the lower extremity. They can be the upper extremity as well. Of course, we have, different pathologies in the upper extremity that may need an orthotic, such as de Quervain's, CTS or carpal tunnel syndrome. It just kind of depends. Or sometimes for someone that's more spastic, sometimes we recommend the resting hand splints. But you can see some of them are dynamic, which I have a example of on the next slide here. So you can see that, for this one, it moves. So you can see how this may, this type of orthotic, this dynamic one, it can help. This is someone for de Quervain. So they can't, if they're unable to move their wrist more radially or ulnarly, just you would basically have this promote those different movements. So orthotics is very different than prosthetics. Prosthetics is an artificial substitute for a missing body part. So this is someone with an amputation. Language changes with time. So nowadays, in the current day and age, we no longer refer to the area that was amputated as stump. We refer to it as residual limb. So that's the proper terminology. So of course, this can be at many different levels on any basically limb. You could be amputated at the leg, at the ankle joint, like at the toes, at the MTP. It kind of just goes up, up, and up all the way to the hip. And then same with the wrist, from the distal end of the DIP all the way up to the elbow. So there's different levels to the amputations. This is just a visual of what I said. But of course, even at the wrist joint, amputations can be even further down. But really, when we get into prosthetics, you can imagine that if someone just had one finger amputated or something, the function is likely preserved for the other fingers. And so we get more into the prosthetics once it's at the wrist or higher. If they need if someone has an amputation on the upper or lower extremity, you can have terminal devices. Now, terminal devices, more for this slide, is referring to the upper extremity. And so these can be like wrist terminal devices is what I'm specifically referring to here. Terminal devices can really vary. They can be passive, where they just cosmetically, they look like, say, a hand, but there's no actual function to them. Or they can be more functional, like, say it's somebody that is in the labor force that needs like some sort of clamping mechanisms or something. They can actually function to help them achieve what they're doing, either at work or, say, recreationally. Say they're rock climbers and they need a certain type of device to help them rock climb. There's also body powered or externally powered devices, where it's battery powered, and there's pros and cons to each of those. So here's some terminal devices. Like I said, these are different examples in photo form. Diagnostically, whenever this is, of course, more for our colleagues in the vascular surgery department, but whenever they're determining what level to amputate, something that can be helpful is actually seeing what their ABI volume is, or their ABI is, where, basically, is the vasculature, are we at risk or not? We've got to have blood flow in order for the limb to be preserved. Here's the lower limb, examples of common areas that where they amputate. And then these are also for Medicare. We basically refer to folks with lower limbs, lower limb amputation by their K level, or what level of what level of function are they expected to achieve after an amputation. So, for instance, like someone that's a Olympic athlete that, say, underwent an amputation and is likely plan to participate in the Paralympics, like that would be a K4. If it were somebody such as myself, who is not an Olympic athlete, but I had an amputation to my lower limb, I don't, prior to the amputation, I don't ambulate with any assistive device, I'd likely be more of a K3. I'd be an unlimited community ambulator, but I'm not doing a specialized activity like track and field. And then it kind of goes down from there. So, of course, if someone's a K0, they're using a bed only. We wouldn't expect them to get a prosthetic because they wouldn't be using it for ambulation. So that kind of concludes amputation kind of care, prosthetics care, in terms of evaluation for that. This is kind of just pivoting to, whether it's someone with an amputation or someone that is recovering from a stroke or a hip fracture, in general, someone has undergone some sort of event that has left them with some sort of deficit that prevented them from going home. Say they've undergone their rehabilitation, whether that be from those different like pathologies that I listed. Well, now what's the plan going home? Well, there's a lot of modifications that may need to be made or may not, depending on their needs. So if it's someone that after rehab is going to be a wheelchair user, of course, you can tell none of these are pictures from Manhattan, New York, but they may need a ramp accessible home, or here we do have a lot of ground level entry apartments and maybe with the elevator access. But these are things that we have to keep in mind. And these are things that our colleagues in the occupational therapy department can help us with in terms of environmental modifications, especially in the home, and as well as physical therapy more for like ambulation status. So you can see that these are some modifications. Here are some in the home itself. OT would help us definitely with this part. So, whether this be medication management, I know that there's some pharmacies that can also, they can provide like more of like in pill packs, they can be delivered where they take them each day and it's already organized. I know that service exists. There's this personal response system. This one with the mirror is just referring to, maybe helpful depending on someone's either visual deficits or they're a wheelchair user, having a mirror so that they can cook and actually see when it's done. So we're not, overly cooking our chicken or whatever they're cooking in there. These are devices like a shoehorn. Basically, environmental modifications are important. And so after their rehab stay or hospitalization stay, they may need some of this whenever they go home in order to give them the most independence possible. Here are more environmental modifications. these are very, very common, probably for me and for you guys in terms of what we would be prescribing for folks in the, the geriatric population. I'm prescribing a lot of commodes, a lot of grab bars, a lot of assistive devices. I don't have any pictures of, but assistive devices such as cane, walker, wheelchair, rollators. These are all environmental modifications that we definitely make sure they have because we want to prevent falls and maintain their independence. Yeah, so this is just in written form, kind of what those pictures showed you guys. If a client is unable to transfer to the bathtub, we would recommend grab bars or a transfer bench or a shower chair. So the therapists really help us out with these in terms of prescriptions. They're able to give the prescription and I can sign off on it closer to discharge. So we want to make sure that, again, they're as functional and independent as they possibly can be when they go home. So this is just a slide to let you know the different rehab settings. I know I harped a lot on acute rehab because that's where I work, is the acute rehab setting where it's 3 hours of therapy 5 days a week. But there are other settings. Of course, there's home. Some folks don't need the intensive therapy and they can go home with home services, which can be PT, OT, speech. You can see the intensity of that. If we're recommending they do that, like through their insurances, this is typically what it would provide is 1 to 3 times a week. So it's definitely less intense than what an acute rehab is, but depending on their needs, that can be the appropriate place for them. Some, it can be a skilled nursing facility. And this is a bit less rehab than, or I should say therapy. It's less therapy than what we would provide on acute, but for some folks, that's the amount that they can tolerate and it's much more appropriate. There can be, with a skilled nursing facility, I can sometimes recommend they go to a SAR or subacute rehab. Some of those places also have the LTAC involved, but the subacute rehab itself is not the long-term placement. It can be more of a stepping stone before they go home, where it's more like 1 to 2 hours of therapy a day, and they can have a bit longer stays. The stays on acute rehab for a more general rehab is more like 2 to 3 weeks, versus some of the subacutes can be more like 3 to 4 weeks with 1 to 2 hours of therapy a day. So that really can depend on their functional status and what they can tolerate. And then we are here to the questions. So I believe that this is also in your guys' handout. So basically, this is going over what I talked about in the very beginning, actually, which is the when we're assessing someone. This is an 81-year-old who's being assessed by his primary care provider, much less energetic. What would be an indication that the clinician would use to assess frailty? So basically, the goal of this is to show like what was that difference between frailty versus the clinical, or frailty versus like disability. So the correct answer, drum roll, would be E, because we're also documenting the decreased grip strength as well as losing 11 pounds. Those were the things we were testing for that frailty. So this was the clinical syndrome that I had mentioned. B was referring to assessing disability, and then C was referring to the handicap. So these are the take-home points about what we talked about. Organize just how your boards did. So we start with the assessment of the disability, which I gave the key differences of. I talked about the rehab potential, which I think it looks like both is very high yield, but in terms of the rehab section of your boards, but also I think is very clinically relevant as well, in terms of the patients that you will be treating. And then after that, the aspects of rehab, all of these different assistive devices, equipment, modalities, orthotics, prosthetics, and environmental modifications, as well as rehab settings. So hopefully we have a little bit of time for me to answer some questions. Thank you, guys.
Okay, perfect timing, Dr. Trentman.
Oh, good.
Excellent time management. So thank you for your talk. I think it's so conducive to or appropriate for people who are geriatricians trying to figure out how to improve people's functionality. So some, I guess, practical questions in the audience. Folks are wondering, we often are asked to write these prescriptions for different orthotics or different durable medical equipment. And often it's unclear to patients and sometimes unclear to providers what's actually covered. Do you have a suggestion for a good resource to figure out what might be covered by Medicare?
Oh, that is a good question. I mean, I know the general Medicare guidelines in terms of, like, for instance, I know for like let's say a walker or a rollator assistive device such as that, if they're hospitalized, I know that within 48 hours before they discharge home, I know that Medicare can cover. But once they're discharged home, I think it really depends on when their last device was that they received. For wheelchairs specifically, it's every 5 years they can get a new wheelchair. So that's something you have to be very careful of in terms of if they are going home and they're like, I had one that I had a patient with an amputation, lower extremity, below knee, that he was recommended a certain wheelchair on discharge, but we wanted to wait because we didn't know if that would be the final wheelchair that he would need. He was pretty healthy. And so we were hesitant to write the full prescription for the wheelchair through Medicare because the one that they were currently recommending was pretty heavy, and we anticipated he was going to get a lot better, that he could possibly have a lighter one in the future. So the wheelchairs you have to be very careful of because it's once every 5 years. The other ones I would actually utilize the therapists as well, like PT and OT, for device device questions, because they will typically try to run through the insurance first. And if they're able to cover it, then we usually run it through the insurance. And then if not, they have like different services. I'm not sponsored by anyone, but sometimes there's something on Amazon that may be cheaper than what it would pay through the insurance, that they can recommend. So I would also utilize the therapists as well to help assist in what's covered and what's not covered.
Okay, sounds like a good interdisciplinary approach.
Yeah.
Great. And then another question for patients, you mentioned that motivation is often important,
Mhm.
the kind of cooperation as well. And so I wondered if a patient isn't able to complete an hour of therapy, would they still potentially be recommended to go to a subacute rehab if they couldn't go home? Or is it a
Yeah.
requirement? They do need to be able to actually do that 1 hour of therapy.
Yeah, I mean, to my understanding, for the subacute rehabs, they are a bit more lenient in terms of, for an acute, it's pretty strict. They have to be able to tolerate 3. For a subacute, because it's 1 to 2 hours of therapy and not necessarily every single day, there's a little bit more wiggle room there. However, I have had an elderly patient, and he's in his 80s. He was recovering from a stroke and definitely could have benefited from a subacute rehab, but he refused all therapies. And that they have to be able to participate in some therapy. It was unfortunate for this particular case because he had the qualifying diagnosis, he had the potential to get much better, but we assessed to make sure he had capacity, which of course is a whole different topic, but he did have capacity. And even after understanding the risks and benefits, he refused all therapies, which was unfortunate. But if they are able to tolerate some, I would typically recommend they at least try for a subacute, definitely.
Okay. Thank you. And thanks for sharing that case that you went through before. Okay. All right. So I think we'll take a short break before we get to questions, board review questions. So we'll take a quick 1 minute break and then I'll be back to do some board review questions. And thank you again, Dr. Trentman.
Thank you. Good luck, everyone.